This podcast is sponsored by Great Seminars and Books. Have you ever thought about how we can become leaders in geriatric care, or how we can break out of the silos of rehab to serve older adults to the best of our ability? Well, myself and Dr. Carole Lewis of Great Seminars and Books will be holding a free webinar titled Breaking Out of the Clinic: Strategies to Become Leaders in Geriatric Care. This webinar will take place on October 9th, 2017 at 7 p.m. Eastern Standard Time. To get access to this webinar, just go to seniorrehabproject.com/great. Hit me.
This is a Senior Rehab Podcast, the podcast for rehab clinicians that want to better serve older adults.
Kory Zimney, welcome to the Senior Rehab Podcast. Thank you for getting up at the butt crack of dawn with me this morning.
Well, I guess if we want to call it dawn, it still looks dark outside here, but we'll call it dawn.
All right. Well, I'm excited to talk with you. You've got quite the reputation in the pain science world, and for me, this has been a terrible struggle in how to implement some of this new theory, or not, I shouldn't say new, it's been around for a little bit, but it's starting to reach the masses. But implementation is a really tough part for me in home health, but than many others. So I'm excited to pick your brain a little bit. But before we kind of jump into that, could you give us just a quick background on your PT journey up to this point?
Yeah. So I graduated many moons ago, I guess, back in 1994. And back then, graduated from the University of North Dakota. Thought I had I had an excellent education, but it was obviously more joint tissue based, as most programs were at that point in time. Practiced for many years, and obviously went to multiple Con Ed courses. Always kind of kept trying to find that magic bullet that was going to fix the next person, and kept going and going, and kept searching and searching, and I've kind of got to the point where I think a lot of therapists do after a while, and recognize, where is that magic bullet? What am I missing? I can get a lot of people better, but there's still some that don't. And during that time frame, I was starting just to do some more reading on my own. Got reintroduced to this thing called a nervous system that I'd kind of forgot about, that there was a brain and a nervous system, when I was learning about muscles and joints and fascia and all those kind of things. And just getting on the internet, and I took a course from Adrienne Lowe, and it obviously turned my world, I wouldn't say upside down, but I think turned it in the right direction, and really started diving me down about the last 8-9 years or so, really trying to understand pain just a little bit further.
Yeah,
and what it means, so through that process, I'd finished my DPT, my transitional DPT from Des Moines University. Started doing some adjunct teaching here at the University of South Dakota. 3 years ago, they had a full-time position open up, and decided to jump more from the full-time treatment world and then into academics to start doing a little bit more research and teaching students and things like that. So I've been here at the University of South Dakota for going on my 4th year now, and having fun teaching the students, and really kind of doing more research and exploring all those things. So there's the quick down and dirty, I guess, of my travels.
I like it. And for the listeners that follow this show, so Kory Zimney is a colleague of Becca Georgie. She did the episode with the Senior Games athletes. So we got a little connection there. I want you to try and explain, or try and introduce the listeners to Adrienne Lowe. He's been mentioned several times throughout this podcast. I haven't had him on, but his work has been mentioned. If someone has never heard of Adrienne Lowe, how would you describe that man?
Adrienne, well, it's been just been so much fun. I mean, Adrienne and I have become close friends, I would say. Obviously, I learned a ton from him early on. We started to do research. I've had an opportunity just to travel with him, learning how to do weekend courses and stuff. And he's just been just so instrumental just in my development in so many different ways. And we've actually become very close friends. He's got a strange South African accent, so you can always tell that. I think that always makes him a little bit smarter. Yeah. He's just one of those people. He's got so much energy, so much passion for our profession, and just this ability that we can potentially maybe change how pain is treated, how pain is taken care of, especially here in America. He's got more energy than most a lot of people combined together, which makes it fun.
Yeah.
And if you get an opportunity to hear him speak, he'll make you laugh. He'll make you think. But most of all, you're going to learn a lot of things. And he has a way, I think, and what for me about the pain science stuff, it's one thing to understand just the neuroscience of it, which is great and it's important. But I always kind of liken it to it's one thing to know anatomy, but you can't treat somebody on Monday morning just by knowing anatomy or physiology. You have to be able to put that into a clinical applicability to be able to use it. And really that's what I think Adrienne, obviously he's worked with David Butler for many years and things. He got to know Louis Gifford before he passed away just through email and phone conversations. But Adrienne's really been able to use all that he's gained from other people and just from his own. I mean, clinically, he practiced using this stuff for 15 years and stuff before he kind of dove more into just doing the weekend teaching courses and stuff, but just using it and really trying to put all that into ways to make it useful on Monday morning when you're actually treating a patient.
Yeah. Yeah, and I would echo all the things you just said. I don't know him personally. The only interaction I've had with him was at CSM this past year, 2016 in Anaheim, and he packed the house and gave just an amazing lecture. And I mean, you're not joking when you said he'll make you laugh, he'll make you think. I shed a tear. The man made me cry during that talk, and it was just super impactful. But then again, you mentioned the challenge of Monday morning, of implementing those things. So I'm curious to know, when you came across Adrienne in this more modern pain science, what setting were you practicing in?
So I actually, I was working an occupational medicine clinic primarily.
Mm-hmm.
So pretty much all I saw was acute injured workers. Obviously, a lot of them had chronic issues overlaid with them, and a lot of psychosocial problems, yellow flags, obviously, that appear just with any time you're injured at work. And so that was my primary treatment role at that point. Like I said, I had worked in community-based hospitals for years, so most of my background had been just your typical outpatient, more rural, kind of somewhat suburban. Sioux City is a town of a little over 100,000 where I live at. But, obviously you'd see anything from the high school kid all the way up to the 80-year-old that maybe had a TIA or a stroke or a total knee, and then obviously everything in between. So that was really, my background was really this general kind of orthopedic background. But I'd also, obviously in the hospital, you'd cover weekends and do acute care, helped a little bit here and there if home health needed somebody, because a lot of the hospitals, that's what you did. You had to cover wherever was needed. We had a rehab unit. So, but primarily when I did most of my stuff, it was more in that outpatient orthopedic, but really with the acute work injuries.
Okay. So say, you go in on that Monday morning into the work hardening setting that you found yourself in. If you just kind of transport yourself back to those times, to that Monday morning, what were some of your biggest struggles in actually being effective in education with patients?
And for me, I think it was one of those things, it's such a, and I talk at courses and stuff, and it's like any other technique that I think we learn. You go to a weekend course and you learn some new manual therapy technique, and the first time you put your hands on the person in class, it's pretty sloppy, it's pretty ugly. By the end of the weekend, you practice it a bunch of times on multiple different people, and you're getting a little better at it. You go back to the department on Monday, you take every coworker that you got, you put them on their side and you crack their back or do whatever you have to do. And, patients that are coming in for an ankle problem, hey, I learned this new technique on your back. Do you mind if I'd practice it on you? So we practice it on everybody. And so by the end of that, after a period of time, we get fairly decent with the technique. With the pain education, I think the hard part with it is the practice end, because it's really awkward and weird to say, hey, do you mind if I explain to you how pain works? It's just not something that you practice, and it's kind of a weird thing that, you think of exercise, you think of manual techniques, and we practice how to deliver those, how to use those. But how do you deliver good education, which good education you give to every patient? I can learn a really cool cervical technique on somebody, but unless you have a cervical problem, I'm never going to use that technique on you. So on a typical day, I might have 1 or 2 people that might need that technique. Patient education is every patient that walks through your door, and we just don't really practice it a lot. And so really I think part of my benefit that I had is because of the just rapid turnover with acute injuries and stuff like that is, I saw 10, 12 new patients a week probably on average. So I got the chance to practice it, my delivery, over and over. And it was probably, like I always joke, it was probably after the first year or two. So after I had about 500 or 1,000 times done, I actually started feeling comfortable with it. And so I think that's the biggest thing is just to get good at it, just like anything, you have to practice it and you have to listen. And it's a lot of reflective learning. So after you try to educate somebody on it, you have to reflect both in action, after the action, to say, what went right, what went wrong, how are different ways I could do that, what words did I use that may have been helpful, what words did I use that may have been harmful, and then just constantly working to refine that. And it takes a little bit of effort and commitment, I think, by the therapist to really be committed to say, I think this approach is going to be helpful and it's going to take a while till I get good at it. And I think that's the part where probably some people struggle is, just like any technique, you try it, and if it works, super, it's great. You put it in your toolbox, you keep using it. If it doesn't, you just throw it to the side and pick on the next exercise or the next manual technique. But with pain science, it's you really got to kind of stick to it. You got to develop the stories that match your own kind of lifestyle, your own approach. We kind of give just our overview of metaphor stories that have worked for us through the years. But really to make it work for each individual is you have to find ways to make that work for the patient in front of you, just like any exercise or anything. There's 5,000 different ways to strengthen the quad, but you have to come up with the right way for the person that sits in front of you. And pain science education is similar. You have to come up with the right story, the right metaphor for that patient, for what they need to hear, and how they need to hear it, and recognize sometimes it takes repetition. It takes just putting slight twist to it. I always kind of laugh sometimes with patients. You'll think you do a great job of educating them. They say they get it. Of course, the next day they come back, they still don't get it. So you try it a little bit different way, and then you try another way, and then you're about your 10th metaphor and you run out of them. So you go back to your first one over again, and they're like, well, why didn't you just tell me that in the first place? That makes sense now. And you're thinking, I did tell you that one, but that's just education. Patients aren't going to get everything the first time. It's just a gradual kind of sprinkling, a dosing, just like with exercise that we have to do with our patients. So I think that's the challenge with it that people find is how to find that right dosing. There is no magical formula, at least not yet, that we've been able to find, and I doubt there really is. It's that constant interaction that you have to develop with that patient. We talk, therapeutic alliance, and really understanding how much information they need and how little they need, and that probably is kind of, quote unquote, I guess, part of the art behind it. There's obviously science behind it, but if I'd have to call the art form, it's trying to be able to figure out how to use all that science based off of that individual in front of you.
Yeah. I have a couple questions from that. The first one being, the repetition, the, trying different things, and just the time that you put in to develop a skill with this. This is a somewhat vague question, but if you could just share in general, what are things that you are observing for or really trying to pick up on that will influence how you communicate to a patient or what you communicate to them?
Yeah. And so much of that, I think, is really understanding that patient. Obviously, we talk, to diagnose a patient, so much comes from the subjective history, and I'm Maitland trained. And so, you were taught to take a solid subjective, because that would lead you, 80% of the time to what it is they have going on with them. And I think really pain science education, it's the same thing. You really listen to their story. And really, I make notes of, the yellow flags, and really listening to all those things where maybe they have something that's that I have to dive into a little bit deeper. The doctor told me I had a slip disc, or I heard it on the internet. So anything that they tell me that I recognize, okay, there might be something that's inaccurate, or that might be driving fear a little bit, or catastrophization. It's areas that I'll want to explore with them a little bit more. And because I want to dive into those areas to kind of get a better feel for what their beliefs are, what their feelings are about that, how that may or may not be affecting them. So really listening for those things, and oftentimes just letting them say those things and not interjecting early on, and just kind of making notes on my sheet. And then I'll come back, and then when I go through, and usually typically my format is to get all that information, dive in a little bit deeper, and again, not necessarily to educate them, but just to gather all my information, go through, do my solid objective examination, and then diving into probably my favorite question is what do you think is going on with you, or what do you think you need to have fixed, and to dive into that a little bit. And then I'll start to say, do you mind if I just take a few minutes to tell you how or why you're so sensitive? And then I start diving into those, what we call those yellow flag areas, those things that I might need to educate them on a little bit, and slowly just start chipping away at those things that they have. Some of them you can tell are deep held beliefs, and you got to go a little bit softer, a little bit easier. Others you can tell they have huge questions on, and those are a lot easier to dispel those myths maybe a little bit quicker with some people in that area.
Yeah, that's really helpful. I've also wondered too, when you talk about how you think, how you reason, and how you implement some of this education. Part of me feels very inadequate to do that, just from kind of the personal standpoint. But then I wonder too, from the professional standpoint. I know, some people, this is a big issue with them. But say there's someone like me that's very, I guess, insecure would be a word in speaking to people about this stuff. And mainly, personally speaking, I worry about the words that I say, because I'm on the back end of healthcare, and home health. And some of the words that people have heard further up the chain, usually from, physicians in the ER, or, just a 5-minute interaction with the physician that has literally, caused so much damage and impacted their life in such a big way. I'm so fearful of being that guy. So, to that fear, what would you say? Am I qualified as a doctor of physical therapy to have these conversations with our patients?
Oh, yeah, absolutely. And the reality is I think we're, that's why I think Dr. Patrick Wall said therapy is really the sleeping giant. And when it comes to treating patients in pain, is we're probably more qualified than anybody else. Because of a few things that we have the ability to do. One is we understand this neuroscience stuff. Even if you were a therapist like me that thought it was all about joints and muscles, you still had to learn the neural stuff. People that learned the neural stuff and remembered the neural stuff are a step ahead of where I was. And so we have the ability to understand the whole neuroscience of how it all works. As therapists, as a general, we have this ability to be empathetic, and we have this ability to communicate and educate and empower patients very, very well. That's why our patients do as good as they do, is we have those skills, which is a part of educating them. And so we have those skills very much just through our training that we got to be a physical therapist, to be skilled at delivering this. I think the fear of saying the wrong word, we talk about the words that we use and choose and all that kind of stuff. And I get worried sometimes. I think we've almost, as we always do, swing a pendulum a little too far, that we've got so people afraid to say anything now. And I know, I'll say things every now and then, and people are like, oh, how could you use that? Wouldn't a person get afraid? Sure they could. And I think that's part of it. You have to watch your patients. But if you say something that kind of shocks them or fears them a little bit, you should be able to kind of notice a little bit of change in their eye or their facial expression. And then all you need to do is just explain it a little further. The problem in healthcare is we say those things, and if we're not being mindful and not really paying attention to the situation, the patient has that feared look on their face, and then we just continue going on, and we don't back up and try to iterate and say, well, let's yes, you have this area that might be, you say the word tore, oh, you tore your rotator cuff, and they get that feared look. And don't worry about it. A lot of people, quote unquote, tear. It's nothing, and you can go back and try to re-explain it with some more depth to try to kind of calm the situation down and stuff. So I think instead of being so fearful of saying the wrong thing, that I think you're going to probably, if you're mindful and aware of it, you're going to say more of the right things. And sure, we're all going to maybe say something that quote unquote could potentially be, a word that kind of harms or becomes hurtful to a person. But if you're mindful and you keep working at it and stuff like that, I think that's going to be very minimal. And when you do, I think you'll become more aware when the patient starts to maybe sense that, and then you can just back up and re-educate a little bit further, give a little bit more context to it and things. So I think if you, like I said, if you really are wanting to do this and you've done some of the study, absolutely you're qualified. Don't be so fearful to not do it. Just do it, but just be aware as you do it. And if you see something that they look a little fearful or something, just add in a little more explanation and to get that moving back the direction you want it to.
That makes me feel so much better, Kory. Thank you. I want you don't have to share, but I am curious. Do you have just a patient story that has really stuck with you in terms of a big mistake that you made that would be a good teaching point for someone like me?
Yeah, well, and I think that's with pain science education, it's, everybody feels like, unless the person's pain instantly, should just massively disappear. I mean, obviously, you read our case studies that we publish, or if you go to a course, we'll tell you how, we did a little education in the patient in 4 or 5 visits. That's not the norm. And I hope people don't, ever get that impression. Sure, we share successes because it's neat to see when it does work that way. But the vast majority of the time, you're just trying to dispel a few myths, a few fears that a patient has, but it's still the therapy that's key to a lot of it, as far as good exercise and manual techniques. And I think sometimes people think that, all you got to do is just talk your patient's pain away. And our research has shown quite significantly, you can't do that. Yes, you need to plant those seeds so that they start viewing their movement and their fears and anxieties differently. And then as you introduce motion and movement to them, their brain reprocesses that sensor information for the movement, and that's what gradually moves them to healthier behaviors, leads them to hopefully moving more in a less fearful way. And then over time, that's then what actually shifts so that they don't have that same kind of pain experience. And so I think that first, with any patient story with that, I can think of a lot of failures, that you said words. Probably my favorite one, it's not necessarily anything I said, it's just where some patients are at. I had a lady, sometimes just to get them to recognize that your brain sometimes makes inaccurate decisions or choices. It's kind of like, why am I having pain? And it's, I don't have it, quote unquote, the x-ray imaging. It doesn't show anything. How can I still have my pain? So sometimes we'll use like the optical illusions and stuff. And I'll use the one with like the checkerboard, with the light casting a shadow over the cylinder and kind of showing how the two squares are actually the same color, yet in the context, they look like there's a dark and a light one. And so I'll do that in the clinic sometimes. And I had this one lady, and so I actually have the little square pieces and I pull them off to the side, and I said to her, so you can see how now they're the same color. And she goes, oh, no, I'm really good with shades. And it was one of those situations, to be honest, I didn't know what else to do. And she was a shoulder patient. And I said, well, let's go get on the arm bike. And it was just that. I realized at this point in time with where she was, I wasn't going to adjust or change that. So I just have to be mindful and just continue with the exercise, and there have to be a different way, a different approach. But and so realize with the pain science, Adrienne's been doing this 20 plus years. I'm going on close to 10. There's still patients that I'm sure I say things and they'll go back to the doctor and they just think it's all in my head. It happens to us. It's going to happen to everybody. Don't get upset by that. You can't fix everybody. That's okay. Yeah.
And I think what puts us in a unique position, you spoke to this earlier, is that, and I'm more speaking to myself, is that even if I do say the wrong words or just screw up royally, I am still a physical therapist that spends, at least 2 to 3 hours a week with my patients. And I can very easily show them that I actually care. And just for me personally speaking, that I feel like that has softened a lot of the reactions to things that I may say that are not the wisest things to say. And that's a very good position to be in. And on the other hand, my wife is in the emergency room, and she does not have a lot of time with people at all. But most of the patients that she sees would benefit from this pain education, and that is such a complex situation to work with. So when she talks about her patients that are catastrophizing and all these things that indicate that they would benefit from some pain education, I'm not jealous of her, because I've got three hours a week for a month or two versus the 5 minutes that she has with her patients. So I appreciate your perspective and just being open to share some of those stories.
Yeah, and I think just again, that going back to kind of that fear of saying the wrong thing and stuff, and I just trying to keep it on a simple, practical kind of metaphorical speaking side of things. I kind of look at it that it's kind of like if you just take diet. Obviously you want to try to eat healthy, good, whole foods and things like that on a regular basis. If every now and then you eat a Twinkie, it's not going to be the end of you. So occasionally if you throw in the wrong word or something like that, it's not going to be the end of it, because in the end, if you're dosing it more with the good, healthy stuff, those little bits of maybe I didn't say it quite the right way, sure, that's a learning tool for the next time. But in the larger, bigger picture, it probably doesn't make that big a difference. And being so fearful not to give anything, that's probably more of a negative, and then worrying that I'm always getting the perfect food. As long as you're dosing it primarily with the good stuff, occasionally you throw in a Twinkie, who cares?
Yeah. You're really good with the metaphors. Do you have any recommendations for people that want to learn more of these, especially the pain metaphors? Any good resources?
Yeah, well, obviously, the textbook, Adrienne Lowe put the Therapeutic Neuroscience Education book, we shared just some of our top story metaphors in there. That's one thing with our certification or our online course that we do, our TPS, Therapeutic Pain Specialist program. We have program. That's what we actually do on our second weekend intensive that you come to is, you have to come with your own story and metaphor. And so every participant in the course has to come with their own, and you get in small groups and share them with each other. And so we really challenge people to expand all the stories and metaphors and make them specific to what you do. And I think that's just it. That's where the time thing comes in. That's where the more people that you get around that are doing this stuff, they'll share stories and metaphors. And I mean, that's, with our group at ISPI, I mean, that's one of the fun things we get together is we just share stories and metaphors and stuff like that. And we just learn from each other. And, I pick up stuff from Steve Schmidt and Terry Cox and Adrienne and Louis Pentadura. I mean, it's really just that just like you learn new exercise manual techniques from other people, it's sharing these stories just as well that you can pick up and learn from each other.
Awesome. And for all the listeners, I'll link to all those things in the show notes for sure. So I wanted to transition a little bit and go into some listener questions. So these questions were fielded on the Senior Rehab Project Facebook group. And we got 5 questions. So, your answers could be long or short, whatever you think is sufficient. Okay. So the first one is Janie Oyakawa. All right, I got it. So she said, or she wanted to know about therapy's role in reducing opioid usage, since it is reaching an epidemic proportion, which, most of us have seen the hashtag Choose PT campaign by the APTA. It's a big topic in our profession. How do you see our role in this epidemic?
Yeah, again, going back, I think, when Patrick Wall, actually what he called us was the sleeping giant in the treatment of pain. And I think that's just it, is that with the number of therapists, with the skills that we have, the ability to educate and teach healthy behaviors such as movement, mindfulness, all those kind of healthy things that are helpful in pain, and our ability to understand it, our ability to educate patients. The problem is that sleeping part, I don't think we've understood our massive, significant ability that we have, and we've yet to try to fully deliver and show the rest of the medical world how much value we have, and actually just the world as a whole and the general public, the value that we have. So I think, obviously I'm extremely biased being PT, but I think in many senses of the word, if done properly, we are that answer, because again, I think exercise and movement along with education is really the key component to it. Obviously, we need to work within a health team. There are patients that are going to need further psychological or counseling type situations. There's patients that will still maybe need some medication use, and maybe they need to taper or to change or alter their medications and have it monitored closely. So a good physician that can skillfully deliver that medication and control and monitor it. There are some patients that may still need some of that because of biological changes that have happened in their body. It's like telling a diabetic that, yes, exercise helps control your sugars, but a type 1 diabetic is probably always going to need, we don't have a cure for it yet. They have a chemical imbalance in their body. And I think unfortunately, some patients do have some chemical shifts and adjustments that exercise alone may not be enough. But the addition with exercise and good delivery of medication, it can be useful. So I think we're really that forefront, that need to be that frontline practitioner for these patients. When you look at just something like fibromyalgia, and when Cochrane Review comes out, and actually gives a gold stamp of approval, which they just don't normally do. Usually they tell you there is no research, or the research that's out there is crap. When they give you the gold stamp approval with fibromyalgia, it says you need to be doing exercise, that is a mandatory treatment. Geez, how cool is that? Cognitive behavioral therapy. That's basically what a lot of this pain science education is. As you're changing people's cognitions and beliefs about their pain. So recognizing that we can do 2 of the 3 things. No, we can't deliver the medication, but we can deliver 2 of the 3 things that are gold level evidence. That's pretty cool, that we have that ability. And it's, and people get worried that, the cognitive behavioral we shouldn't be getting in the psychology. One thing that I've had the fun opportunity is talking and working, and we brought in psychologists to teach at our conferences and stuff. I was just teaching a course a couple weeks ago in Fargo, and there was 2 psychologists there. I do love that group of healthcare practitioners. They don't feel any turf battle problems. We always get worried of stepping on turf, that we're on somebody's toes, and, they welcome us, they open their arms, they give us information. Francis O'Keefe was at our conference this summer, and he was just more than glad giving us information. He does a lot of work now training therapists in these things, because there's a lot of us as therapists. So we're, like I said, when you have a huge epidemic, pardon the language, you need a huge effing army. We have a lot of good therapists out there that can do this, and I think we play a key role in that.
Yeah, and I'm glad you you echoed the need for the interdisciplinary team, because it is very, I don't know, just from my observation on the interwebs and particularly social media, it seems that we can easily oversimplify the issue in saying, just choose PT. That's all you need, to fix all your problems. And, that's just not the case. And I've mentioned my wife several times. This is just a big conversation we have, because she is, in the ER dealing with this, the front line, of, giving Narcan to a patient that's, OD'd, and then the next person is dependent on opioids. So she's in the thick of it, and we are as well. But just to see how incredibly complex this problem is, to where we need a team approach, and everyone's got to be at the table to help these people. But I do want to dig in a little bit more. If I recall, your interview with Jimmy McKay on the PT Pintcast, which is awesome, by the way. I think you said you work with medical residents. Is that correct?
I did, because obviously here at the University South Dakota, we're tied in there. Obviously, we have a medical school. There's a residency program that we're attached with. So I went up there and just did a noon hour kind of luncheon as part of one. They have different educational training sessions, kind of the lunch hour, lunch and learn type of thing. So I've had an opportunity to go up there and talk to the residents in regards to just a short, kind of understanding pain and understanding, how therapy can be involved in that process. But it's mean, I wish we could do more, across disciplines and things like that, here in the academic world. That's one of my goals, coming here to USD is, first within our health sciences, I have a little bit more opportunity and I'm starting to spread, pushing that information out. We have an addiction studies program, and I've been in contact with him and talking how therapy can be involved. I now teach the neuroscience, so I get to do a lot of pain education and understanding pain neuroscience. It's a combination for our PT and OT classes. So I've taken that class over, and so starting to spread some of this throughout the other healthcare disciplines. Eventually, hopefully, maybe getting into the medical school. Yeah. We'll see how that goes. Yeah. But again, I think it's just it's going to take time. I think it's headed the right direction. But hopefully we can get more and more disciplines really understanding this. That was exciting. I was like I said, I was up in Fargo, North Dakota at a hospital. I was there a year ago, and I did our therapeutic neuroscience education course. And this year I went back to the same place, and they had one PT that was in the room because she had just graduated 6 months ago, so she hadn't been to the first one. But the rest of the room was full of their pain program, which was nurses, like I said, psychologists. Wow. A physiatrist, a nurse specialist, and things like that. So it was a fun audience because there was more of the other healthcare providers than there were PTs. I definitely felt like the outcast, but it was good. Like I said, to see that we can. It really does have to be this team approach. Pain is too complex to think any one discipline can master and solve it. That's never going to happen.
Yeah, that's encouraging to hear all those different disciplines interested in it. So thank you for getting out there and speaking to those people. So. Next question is from Matt Danzigers. He has a blog titled ptbraintrust.wordpress.com. I've read a few of his articles on here. Solid guy. He asked, what does Kory consider when pain education falls short after multiple visits? And I think we touched on this a little bit, and I'll just add to that after multiple visits, because many of us that listen to this podcast, we interact with people that, have had decades of maybe harmful beliefs about themselves, about how their body works, about their pain and their issues. So what are your considerations when, things just aren't working as you'd intended?
Yeah. And that's just, everybody's at a different phase of where they're ready to hear it. And I'd love to hear Matt's answer to this as well, because he's got just as probably much experience in this stuff as I do. But, I really think, we have to recognize that some patients just aren't ready for it. They have too many barriers. And a lot of times these thoughts and things like that, if they're at that low level, kind of what we kind of talk about the transcervical change model, if they're at that pre-contemplation stage, they're going to need time just to process this stuff. So basically, all you can do is just drop a few things that's probably going to alter or be a little bit different to what they maybe believed. And you're just going to have to let that sit and percolate inside of them. How long is that going to take for them to contemplate, to come back and say, I've been thinking about what you said, and I have some questions about that. That could sometimes be a week. It may end up being 2 years. And I think sometimes you have to recognize that certain people, they're just not ready, or they have too many other misheld beliefs. All you can do is just throw out these nuggets just to make them stop to think and wonder, well, why does that work that way? How can somebody not have an arm and still have pain in their arm? How does something like that work? And just let them percolate, but they have to come back and have to ask the questions. I can open up a fire hydrant and dump out all sorts of education, but if you're not open, you still don't necessarily have to take a drink out of the fire hydrant, even though you're getting sprayed by water. They have to be open to it. And if they're not, then you have to recognize it's not yet the time or place. So you just drop a few of these nuggets, let it percolate inside of them, let them eventually come back to ask the questions. Once they come and asking questions, then now you have them in a better space to be open to the education and changing and altering their beliefs. So again, if it falls short, if it isn't working, don't just like anything else, if an exercise isn't working or a manual technique's working, don't keep doing it over and over again. Sure, you try to alter it, you try to modify it a few times, but after a while, you have to recognize we need to go to a different approach, and along those ways.
Yeah, that's helpful. I think that your response there really speaks to the next question, which, my gosh, I'm not jealous of Nicole. Nicole Nixon,
Yeah.
she said, I have a 75-year-old patient with beginning stages of dementia who just had a cervical fusion. He was under the impression that it was going to help him walk better after 2 years. That's not the case. So the healthcare team is trying to navigate an underlying neuro issue affecting his walking, but the patient is still adamant about a lumbar fusion and opioids to help. She needs some ideas. And I think you gave her plenty in that last response. Are there any others that come to mind when you read that very complex situation?
Yeah, a lot of people ask that, does pain education work, with dementia or head injuries and stuff like that? The truthful answer is we don't know. We just haven't really studied in that population a whole lot. We do have in some of our areas, and people in the VA, we're working with them, and obviously they're coming back with TBIs and post-traumatic stress disorders and things like that. And just like anything, we don't fully understand the dementias and all that and how the brain's processing. But nonetheless, we still try to provide it. We know that if you provide it, the good news about it is, unlike a fusion, the complications are a lot lower with delivering education, whether they understand it or not. And I think sometimes with these people that, if they have a distinct belief, of why he thinks, a lot of times you just have to explore with that person. So why do you think the fusion is going to help you?
Yeah.
And just find out what they think, explore into that, and just to try to help. And anytime they bring up something, you have to, well, it's because, I had gone numb. Well, your image shows this, which means it doesn't do this. So why do you think that? You just have to kind of slowly walk through that. It gets hard because sometimes there's questions that you may not be able to come back to, or answers that they have. But you have to just help them kind of explore that kind of the Socratic questioning, challenge some of their beliefs in that fashion to let them kind of come to the answers. Like I said, I think when we deliver good pain education, when the patient can come to the questions and eventually come to the answers, that's when it's most effective, as compared to just me giving you the answers and stuff. And usually in healthcare, that's what we like to do. We like to sit you down and bombard you with how much we know.
Right.
And it just doesn't seem to work as effectively as when I can have them ask the questions, and then I can provide some information or provide it in a way that they will have to answer it on their own. And so with somebody like that, I think obviously those are the challenging cases, and those are some of the ones that, again, we don't have all those answers yet to help everybody. But I think trying to maybe just have him question through what we're, be honest, what we do see, what it is that we're still trying to find out, and just being authentic as far as what we do know, what we don't know with the condition that he has, that we're still exploring things. These other things might be a part of it. A fusion, this is what we do know about fusion, that if you have these signs, you have significant, saddle paresthesia, you got muscle weakness, a certain level and stuff like that. Absolutely go in and get your lumbar fusion, but go ahead absolutely and do that. Your outcome is going to be great. You were in a major car accident and you have shifting of your vertebrae. Absolutely have a fusion. Those cases, we know the outcomes to those are great. The other ones, flip a coin. Yeah. And some patients, they might be okay with flipping a coin. And sometimes it's educating them. Great, if this is where you're at, let's go forward with it. But recognize afterwards, you're still going to need to move. You're still going to need to do things. Recognize if it does help your pain, wonderful. If it doesn't, that's okay. Then we know that wasn't the issue. And then we move on to the next thing and help them not look back negatively. So you can kind of preemptive education. So if it doesn't work, that they understand that, hey, maybe this won't work, but I'm willing to take that risk. Just be a part of that shared decision making. But ultimately, it's the patient's choice with their autonomy to pick what they want to do. Just help make sure that they're making the best, most informed choice they can.
Yeah, that's good. And when I read that question, the first thing that came to my mind, if I were to add my 2 cents, is just the importance of just kind of this people around that patient. That there's a unified message or belief, whether it's the family or a caregiver or the physicians involved. If there's a way to for you all to have the same perception of this patient, of seeing that lumbar fusion may or may not be the best thing for him, but just the pain education and further going down that neuro route of seeing what's going on could be helpful. But yeah, Nicole, I'm not jealous of you one bit right now. All right, so Christine Cabral, she asked, is it correct to tell my patients if they are at an 8 or above on the pain scale, then their pain is not under control and they need to contact the doctor? Is there work to be done is there work done to be done therapy-wise if the pain is that high, or do we wait until the pain is under control? And I will raise my hand, say, I deal with this all the time, and everyone listening has a similar situation. So is there work to be done therapy-wise if the pain is that high, or do we wait until the pain is under control?
Yeah, I think there's always work that we can do from a therapy standpoint. I don't care if you're a 12 out of 10 or where the person is at. In regards to the number, to me, the pain number is just, I think sometimes we look at that pain scale number and we still correlate pain with injury. Mm-hmm. And if we see the number real high, we think there must be a lot of injury. And even though maybe we consciously know that, because we're trying to gather and just take a hold and grasp what this pain science stuff means. But I still think there's part of us that still sees 8 out of 10 going, God, they must have something a lot wrong with them. So they should see a doctor first and not therapy. Mm. And I think we need to recognize, one is you can have 8 out of 10 or 12 out of 10 and have phantom limb pain, and there's nothing, quote unquote, physically wrong with somebody. And somebody else might say it's 0 out of 10 and they got a broken bone. We see stories on the internet that people have a broken bone and they'll say it's 0 out of 10. Well, does that mean you should start therapy? No, you probably should get the bone set first, right? Yeah. And so don't let the number really do anything. To me, the number just tells me, if nothing else, it tells me how much distress the person is in, or how much difficulty they're having coping with it. And so I don't think there is any number that we should or shouldn't do therapy with. If they say they're a 0 or if they're a 12, if there's something that we can work on from an impairment standpoint or a functional standpoint, we can provide therapy. And really, if their pain is that they can't move or we can't touch them, kind of what we call the too hot to handle patients. So if you had somebody with, CRPS or something like that where we can't touch them, the therapy then that we maybe need to do is probably more along the graded motor imagery standpoint. And we probably need to begin there in regards to our therapy, where we can actually start working on that body part, but not by having to do quote unquote traditional therapy where we're exercising, moving it, stretching it, loading it, those kind of things. We probably have to start more back a little bit from the traditional therapy standpoint and go into the graded motor imagery and work on the, make sure the laterality is in place, make sure we can do sensory discrimination training, do some motor imagery, maybe some mirror box. So we probably have to go to those type of things. If the pain is so out of control that I can't touch or can't move the area, then I probably need to provide my therapy along those lines.
Yeah, that's a good thought. This is my personal question. So I'm in home health. We have to do, the pain scale every visit, and it, there's a lot of weight put on it. I'm at the point now where I wonder if me asking that question does more harm than good. What are your thoughts on the pain scale?
Yeah, I mean, it's one of those things patients know. I mean, we've trained everybody so heavily now, they know it. Mm-hmm. I try to play it off as little as possible. I want to know what's your function.
Yeah.
And as therapists, that should be our biggest question. And really, I was actually I was listening to a physician talk about, again, proper dosing of medication and stuff like that. And it was neat to hear him even talk about that, when he gives pain medication and opioid and stuff like that, it's not if their pain gets less, it's if their function improves. If he doses them so high that their pain actually drops, but they're basically comatose and can't do anything, he goes, that's the wrong dosage. Because if they're not functioning, then that's the wrong dose of medication, which was pleasant to hear that they were, that he was talking that the right dosage doesn't mean your pain level goes up or down. It's can you function better? And so really that's with patients, that's what I want to know. Sure, I have to write down the number. Patients will come in. If I have to ask them the number, I'll say, what's your number? I even avoid the word pain. Patients know what you're talking about. Right. They'll tell you, I'm an 8 today. Great. How are you moving? Are you able to do this? Did you do your exercises? You were supposed to walk that long. Were you able to walk along? Why couldn't you walk that long? Why did you go further? That's what I want to know is how you're functioning. And patients are still stuck on pain. I'll say, well, how are you functioning? How are you moving today? Oh, I'm a 6. Great. I'll write it down. Now, how are you functioning? So sure, we write the number down. Unfortunately, we've trained our population and the world that we have to give that number. But yeah, to me, it doesn't mean much. It's that person's sense of how well they're coping. It doesn't tell me anything about their nociception. It doesn't tell me how much tissue damage is going on. To me, the pain scale number is just their subjective report of how well they feel like they're coping and how much they're in distress. And so, sure, it's helpful to understand that. I would say as I'm doing things, is it making it worse? Yeah, I don't want to do that. We need to modify. We need to shift. We need to adjust. I get less worried about the number as I use terms like, is it tolerable? I want you to exercise and do things where it's still tolerable. If it's a 8 out of 10, 9 out of 10, but I can still tolerate it, great. Let's keep exercising. Yeah, it's to a level I'm not sure it's starting to bother me more. Okay, let's modify, let's adjust. So yeah, some people, if the pain goes more than 1 or 2, then, I'll do it till it goes 1 or 2 higher. I don't even worry about that so much. I want to just know, is it tolerable and, are you able to cope with it and work through it? So, yeah.
What do you think the future of the pain scale is? Do you think it's on its way out?
No, I mean, it'll be around forever. Yeah. Hopefully we use it. Like I said, it still tells me if the person's coping or handling their situation. We have to recognize it's not a scale of how much tissue injury you have. It's not a scale of how much nociception is going on in an individual. It's more of a scale of their subjective experience of how much distress, how much problem or difficulty they're having.
That's really helpful.
And just take it as that. Yeah.
That's super helpful because we often do, ask what that number is and think, oh my gosh, they're at 8 or 9, something's wrong. But it's
and just because the number goes up doesn't mean they're damaging anything any further. Yeah. It just means that their body for some reason isn't coping, isn't liking what it is that you're doing. You're adding more fear. That the body's seeing the movement as more fearful. The body's and the brain are seeing it as something potentially more dangerous, and things like that. I mean, obviously within reason, if I'm bending somebody in half and throwing 500 pounds and they say their pain going up, maybe you're causing some damage then. I mean, obviously within reason. But again, if you're doing normal motions and movements and their pain's going up, you're not injuring them any further. Right. It just means for some reason their body is perceiving that as potentially more dangerous. Why it sees it as more dangerous, that's what we want to try to figure out. Is it just that the load doesn't feel like they can tolerate it? We need to be a little more gradual graded in our exposure program with that. Maybe they have fears and anxieties about it. Maybe we need to shift their beliefs about it and gradually introduce, the load to them, whatever it might be. So the number is still, like I said, helpful. It's where they're at. Recognize the number it's going to fluctuate. That's normal. We always expect like it's a linear thing, like it's just going to go straight down or straight up. Even from a nociceptive standpoint, just from information, you have different cytokines coming in. You have pro-inflammatory and anti-inflammatory cytokines. Those come and go. Even if it's a true acute injury, with true inflammation going on, that nociceptive information, as far as a sensory input into the system, should be constantly changing up and down because you have pro-inflammatory chemical coming and anti-inflammatory molecules, the cytokines coming in and out constantly through the area to provide a normal healing process. So that's changing just the sensory input on a regular basis. It should yo-yo up and down. That's a normal response. We kind of look at it, if it's not going linear, that it's abnormal. Yeah. Well, really, if it was purely linear in fashion, that's actually, if anything, if you truly could measure nociception and measure that information, it would actually should yo-yo up and down. So
that's a good point. So I want to be respectful of your time. We just have 2 more questions. So Nate Byford asks, and this is more of just kind of the physical assessment. Yep. He said, are there any neurodynamic assessment accommodations for the older adult ortho cases?
Yeah, I think, just positioning wise, I mean, with neurodynamics, obviously, we talk about, like head position and things like that, just as long as you're consistent, so if you have somebody that's got some major kyphosis or something going on, and you have to stack them up on 3 pillows, or if you're, they don't like to lay all the way flat, they got some hypotension or something, and you have to elevate the bed, just test them in that position and just always retest in the same position. Because really when you're doing your neurodynamic assessment, you're just looking for changes. Obviously, if they have, shoulder issues, for example, like an upper limb 1, you're supposed to get into 90 degrees of abduction. Well, if they can't get their shoulder into that due to some arthritic, significant arthritic changes, you can always do the upper limb 2A, where you add in more shoulder depression. And so you can modify those things in those directions. So those are just a couple that kind of come to mind. But the big thing is whatever position you can get him into, just as long as you repeat it and do it the same way the next time, you're fine. The nervous system, you're just trying to see, can you make changes?
Awesome. All right, and the last question, my favorite. So let's say we're at CSM, you have every geriatric rehab clinician in the room, you have their attention for 30 to 60 seconds. What would you want them to know?
What would I want them to know? Pain is complex, but the treatment doesn't necessarily have to be. I think if you help a patient understand it better, you explore the person's why they hurt maybe. You can't tell somebody why they hurt, but you can explore it, and the patient oftentimes will come to an understanding of why they hurt. And you can help make patients a lot healthier by exercising and moving them, and just doing it in a context that's less fearful for the patient, and gradually grade and exposure them to motion and movement. And many, many patients are going to do better.
That's awesome. You're so encouraging. You're making me feel better about this complex issue. But I really do appreciate your perspective and just how you break things down. And I'm sure the listeners will agree with this. But for me, I read a bunch of blog posts. I hear the theory, and that's been really helpful just to hear, to see pain as more complex than the gait theory. Yeah. But you've provided very practical tips that I can go use today, when I go see my patients. So thank you for that. And I'm just really encouraged, because it's hard to find the practical tips, easy to find the theory. So thank you for that. If people have any questions for you, want to learn more about your work, could you share a website or two and maybe a Twitter handle for people to reach out to you?
Yep. So Twitter's at Zimney KJ, so Zimney KJ. And so you can find me on the Twitter sphere there. Blog-wise, the EIM blog, I probably about once a month, once every, like I said, about every 3-4 weeks. Usually on Thursdays is when we do our pain science. So myself and we have other people on our team that blog usually on Thursdays on the EAM site. We'll usually have kind of a pain science information, so you can find me on there blogging occasionally. Obviously, if you're interested in more courses and things like that, you can go to our ISPI, ISPIinstitute.com website, and that's where the list of our courses and, like I said, our certification programs and things like that, along with other resources as far as some of the books that we do. You can get access to there, go to the OPTP site where the books are sold. And so there's resources there and stuff for them.
All right. And for all the listeners, all those links will be in the show notes and can be found at seniorrehabproject.com. And once again, Kory, Zimney, thank you for your time.
Yes, thanks, Dustin. It was a lot of fun.
Hit me. Thank you for listening to the Senior Rehab Podcast. If you enjoy this content, I highly encourage you to go to seniorrehabproject.com, where you can find more helpful episodes, lots of free resources, and to see how you can become a game changer and influence the direction of this movement. I appreciate you, and I'll talk with you soon. But in the meantime, do not forget to stay funky. This podcast is sponsored by Great Seminars and Books. Have you ever thought about how we can become leaders in geriatric care? or how we can break out of the silos of rehab to serve older adults to the best of our ability? Well, myself and Dr. Carole Lewis of Great Seminars and Books will be holding a free webinar titled Breaking Out of the Clinic: Strategies to Become Leaders in Geriatric Care. This webinar will take place on October 9th, 2017 at 7 p.m. Eastern Standard Time. To get access to this webinar, just go to seniorrehabproject.com/great. This podcast is brought to you in partnership with the Geros Collective, a podcast network that's redefining old and equipping healthcare clinicians to better serve our aging population. Find out more at geroscollective.com.